The Admissions and Transitions Optimization Program, ATOP, is an initiative through Health Insight Nevada to reduce avoidable hospitalizations among long-term care nursing facility residents. The initiative is funded by the CMS Innovation Center. Health Insight is a private, nonprofit, community-based organization dedicated to improving health and healthcare. It operates in 5 western states: California, Nevada, New Mexico, Oregon, and Utah. In Nevada, in addition to the ATOP program, Health Insight is the CMS-designated Quality Improvement Organization. It manages the statewide health information exchange and operates several other quality improvement-related programs. Health Insight Nevada was selected by CMS as one of 7 organizations across the nation to lead the initiative to reduce avoidable hospitalizations among nursing facility residents. In September of 2012, Health Insight launched the Admissions and Transitions Optimization Program, or ATOP. ATOP focused on education and utilization of proven quality improvement methodologies, such as the Interact tools, in 24 nursing facilities throughout Nevada. Health Insight Nevada's ATOP program has recently been awarded Phase 2 by CMS through 2020. ATOP2 will continue the clinical intervention in Nevada facilities and introduce a new payment reform model marked by the addition of new billing codes and payment rules aimed at both long-term care facilities and providers. In Nevada, we will continue working with the 24 facilities involved in Phase 1 and will be recruiting all eligible practitioners. In Colorado, we will be recruiting approximately 24 facilities and eligible practitioners to participate in the second phase of the initiative. Recruitment for the program is aimed at practitioners in both Colorado and Nevada who meet the following criteria: those who carried an average panel of at least 7 long-stay, fee-for-service Medicare beneficiaries in the affiliated participating long-term care facility over the most recent 6 months, have all licensure and certification in good standing, do not have any sanctions, indictments, probations, corrective action plans, or judgments imposed in the last 3 years relating to fraudulent or abusive billing practices, and are not excluded from participation in the Medicare or Medicaid programs. Finally, interested practitioners must submit a non-binding letter of intent. Phase 2 looks to reimburse both long-term care facilities and practitioners to treat certain conditions in-house rather than admitting the resident to an acute care setting. The new reimbursement rules apply to 6 specific conditions. Therefore, the new payment model is designed to add new billing codes for facilities who treat patients for the 6 qualifying conditions, increase practitioner reimbursement rates for treating beneficiaries in a long-term care facility rather than transferring to an acute care setting, and reimburse practitioners for their participation in patient care conferences. The 6 conditions that will be considered under the payment reform model are pneumonia, dehydration, congestive heart failure, urinary tract infection, skin ulcer and cellulitis, and COPD and asthma. Practitioner billing codes for these conditions may only be applied for the first visit in a long-term care facility in response to a beneficiary who has experienced an acute change in condition. A practitioner may bill this new code for the service even if the service is furnished because a long-term care facility suspects that a beneficiary has one of the 6 conditions, but upon examination, the beneficiary is found not to have the condition. There are clinical criteria for treatment of eligible beneficiaries. More detailed information will be provided for those practitioners interested in learning more. There are 3 components to the payment reform model: 1 that pertains to the participating facility and 2 that pertain to the practitioners. Payment to a facility for treatment in-house of any of the 6 qualifying conditions, payment to a practitioner for treatment of qualifying conditions on-site at the long-term care facility, an increase of approximately $70 in addition to the existing fee, and payment to practitioners for care coordination and caregiver engagement for beneficiaries. This rule change would cover up to 1 care conference per year. Practitioners included in this model are physicians, both MDs and DOs, nurse practitioners, and physician assistants. Please note that payment for NPs and PAs is at 85% of the physician's fee schedule. The following table depicts the proposed Medicare physician fee schedule amount for fiscal year 2016 and the corresponding code. When a practitioner sees a beneficiary in the long-term care facility for an acute change in condition, the practitioner would be paid for the service at the equivalent of an acute hospital initial visit code. Subsequent visits would be available at the current rates using existing codes. Increased practitioner involvement in person-centered care coordination with beneficiaries is also a priority under ATOP Phase 2. This model includes a new billing code for practitioners to participate in nursing facility conferences and engage in care coordination discussions. These discussions have CMS-designated parameters that need to be met, but overall, they encourage coordination of care between the beneficiary or their legally responsible representative and the long-term care treating staff. Beneficiaries are considered eligible if they have resided in the long-term care facility for 101 cumulative days or more, starting from the resident's date of admission to the facility, are enrolled in Medicare, Part A and Part B fee-for-service and Medicaid, or Medicare Part A and Part B fee-for-service only, have not opted out of participating in this initiative, reside in a Medicare or Medicaid certified long-term care facility bed, are not enrolled in a Medicare managed care plan, and have not elected Medicare hospice. To be considered for participation, eligible practitioners must submit a letter of intent to participate, an agreement upon approval, and a commitment to payment reform initiatives and beneficiary needs. Don't miss this opportunity to be at the forefront of payment reform. To take advantage of these payment incentives or to learn more about ATOP2, email Adriana Mahoney at amahoney@healthinsight.org or call 775-530-4215.